packing my bags tonight, George, and heading up to Brisbane tomorrow to see you at the IT and Aged Care Conference.
I haven't packed mine yet and I'm flying out in 3 hours.
Oh, God, okay, we're going to get on to the show then. All right, George, let's get going.
Let's rock and roll.
All right. Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topics show and I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
George, this episode is going to drop on Friday where we would have just wrapped up ITAC, but I'm going to see you tomorrow and for the next couple of days at ITAC. So have you been doing anything or is it just all ITAC all the time at the moment?
Look, ITAC now in its 19th year is a big deal and I've been involved in it for a long time. By the looks of it, we're going to have record numbers. But it's been a pretty interesting week here. I actually did a podcast with a local company about AI in aged care. I attended the Australian Clinical Entrepreneur Program's pitch program here in Sydney, which was interesting. Interestingly, that it wasn't very tech. There were a lot of non-tech stuff being discussed there. And as you and I have discussed many times, I've spent a lot of time going through a whole stack of emails about AI. I mean, I think I need AI to analyze my AI emails because it's just getting to the stage where every second email has an AI pitch in it.
Oh,
fun week.
Absolutely.
How about you, Louise?
This week has been good, but since we last spoke, I said that we were going on a family trip to Canberra, and that was really special. And hats off to the Australian War Memorial people and their archivists there, because my dad's portrait, it's in archive, and they've got a beautiful facility there. And we made the appointment, and they weren't rushing us out. And there was like 10 of us, right? So there's a lot of people. How many more photos? Have you had a picture with the portrait? All that stuff. And then my mum had a lot of stories from my dad about the portrait and what he remembers and who else was in it in the background and everything. And the staff there were making note of mum's stories. And then they said, actually, when they looked up my dad's name, they found they actually had some photographs of him in service as well. And they had got them out and said, would you like to see those too? And we're like, oh
wow.
My God. So just hats off to the Australian War Memorial. Lovely staff, but also the building itself, aside from the fantastic displays, the building is incredible. Like it's worthwhile. Any Australian listeners or international people, if you visit Canberra, go to the Australian War Memorial. It is completely free to visit. And like, if you've only got half an hour, you don't have much time, just walk around the outside, go to the Pool of Reflection and the Hall of Memory. It has such drama and beauty, sort of like a chapel, but it's not religious. And oh my God, it was the sort of thing you'd see in Europe, like this quite small room, but 3 stories tall, I think, covered everywhere in mosaics, all hand placed. It was really beautiful and it houses the tomb of the unknown Australian soldier. It was really beautiful. And yes, we laid a wreath for my dad and actually for my grandparents too, who both fought in World War II. So it was really emotional, but a really good time and really appreciated having that opportunity.
I'm glad you had the opportunity. And like I said, it sounds like it was a fantastic experience. I haven't visited the War Memorial for quite a few years. I know it's had a major revamp since last time I was there. But last time we went there, again, it's just amazing the resource it has. And we actually got a tour by a ex-military person who took us through sort of part of it. And that just gave us a whole new insight into it. So I think it's a really important thing that we have in the Australian War Memorial. And times at the moment are scary, but the War Memorial reminds us about how we got to where we are today. So.
Yeah, that's right. Yes. And that Anzac Day dawn service at the War Memorial as well, beautiful. And they're always lovely services. But again, the way the building was lit up, they had projections on the building. You're sitting around in the cold and dark, and it was close to a spiritual experience. It was beautiful. And the people who spoke were great. They even had one of the people who spoke, her family were refugees who were rescued by the Navy from a boat. And now she serves in the Air Force. It was really special to hear people's stories. Yeah. And then now I'm packing my bags tonight, George, and heading up to Brisbane tomorrow to see you at the IT and Aged Care Conference.
I haven't packed mine yet and I'm flying out in 3 hours.
Oh, God. Okay. We're going to get on to the show then. All right, let's do it, George. Well, George, another 2 weeks have gone by since our last Hot Topics episode, which means, of course, there is a plethora of AI-related announcements. We're going to focus on two of the major clinician-facing AI releases from big tech companies. These both position AI as a clinical partner to clinicians. So firstly, we've got Google DeepMind. They've just unveiled what they're calling an AI co-scientist and co-clinician. The key idea here is that this isn't just a chatbot that simply retrieves information. This is a system designed to reason through complex problems. So it can take a clinical or biomedical question, break it down into components, generate multiple hypotheses, evaluate evidence, and iteratively refine its answers. So it's like a multidisciplinary care team working through a case. An example of this is, so instead of saying, what's the guideline for this condition, instead the clinician would ask the co-scientist, given this patient, these variables, and look, here's the stuff that is uncertain. What are the possible explanations and how should I think about them? So like this model from Google DeepMind is much closer to clinical reasoning than just information retrieval. So Google DeepMind are really framing the future as triadic care, which we've talked about before, George, with patient, clinician, and AI agent working together under the clinical authority of the physician. Now, one other announcement is again from OpenAI. They're always so busy over there at OpenAI. Now, they've launched ChatGPT for clinicians. It's much more immediate and tangible, at least for our US-based listeners. Those outside of the US, including us, unfortunately, we do not yet have access to have a play. But ChatGPT for clinicians is free, purpose-built version of ChatGPT for verified healthcare professionals, and it's designed to be used in day-to-day clinical work. So it does things like draft clinical notes and referral letters, summarize patient histories, explain conditions in plain language for patients, support differential diagnosis thinking, and it can also pull in and cite medical literature. It also has pre-built workflows, so things like discharge summaries, patient instructions, and especially those sources and references, which are absolutely essential in a clinical context. And so the reason I put those two stories together today is I think when you put them together, you've got DeepMind pushing the frontier of AI as a reasoning partner. We've got OpenAI operationalizing AI as a daily clinical assistant. And this is what I think is really interesting because the last couple of years we've been talking about chatbots, AI scribes, automation, efficiency gains. But now what we're seeing is the emergence of AI that it's starting to participate in the thinking. So it's not just documenting decisions, but actually shaping them. And that is a very different proposition. What are your thoughts on all this, George?
Look, I think we are really seeing an evolutionary stage here. We started off with a whole bunch of AI tools. We've seen a plethora of tools. Now we're starting to see an amalgamation of those tools into ecosystem types or platform solutions. It's hard to describe because this is a whole new world. But the Google paper in particular caught my attention, the concept of co-clinicians, the fact that it sits beside the clinician, plays an active role in determining their reasoning, at the same time still keeps the human in the loop. Now, when I first read the paper, I thought, is this keeping the human in the loop something they've done to pacify, or the discussion around AI is taking over our jobs? And when you speak to a lot of people in healthcare, there is some very real concern that job descriptions are going to be drastically changed and people's roles in healthcare delivery is going to be changed. And we've seen that in other sectors. We've seen announcements that companies have literally laid off tens of thousands of people because they're replacing them with AI in the coding world, in the content creation world. Doctors, nurses, allied health workers, we all do rely on our jobs to pay the school fees and feed the family. So there are some concerns there. But Google, to their credit, seem to do deep research, DeepMind in itself. And I've always been a big fan of the DeepMind model, not just because now Dennis Hassabis is part Greek, but because it actually seems to be a scientifically based process. I was listening to a podcast fairly recently by Eric Topol, who was interviewing someone from DeepMind, and they seem to be a purely scientific company. They have a Nobel Prize laureate as one of their founders. That's a buzz. But they seem to be digging deeper and deeper into healthcare. And I guess this is the evolution of where this is going. We started off with lots of bells and whistles when ChatGPT came out, but now we're starting to see solutions that may well be that turning point where AI becomes a core part of healthcare delivery. We're not there yet. a lot of these papers are still only being read by people like you and me and people who listen to the podcast. And the average Joe Blow in the street probably has no idea what's happening, but it's starting to impinge more and more into the systems. I deep dived into the DeepMind paper because, to their credit, they made it publicly available and it was easy to read. I tried to have a look at GPT for clinicians. It locked me out, even though I have an ARPA number. And OpenEvidence, for example, required me to use my ARPA registration to get access to it. ChatGPT, not yet available in Australia. So I am going off what they tell us about it, and I would like the opportunity to dig into it deeper. But again, as you've pointed out, they seem to be filling in a whole bunch of gaps in existing EMR systems. And the reality is the EMR and the AI world is really starting to merge. And I listened earlier to a podcast from Judy Faulkner from Epic, how they're integrating AI into their solution, but they don't have the same sort of resources that OpenAI have to invest. Just this week, we've got the court case between OpenAI and Elon Musk, and the number of zeros in those numbers they talk about is astronomical. Astronomical.
That's right. Yeah, absolutely. And you're right, George. I mean, we're going to be talking about this a lot. But I think if you're a traditional software player or even a new player in software model, like, what does this mean for them? Because I could see a future where it's no longer about having your GP desktop system, your hospital EMR system, but it's about a platform, and you'll be able to collect data in multitudes of ways using AI to collect that data. How it's stored and moved around and used and everything like that will become quite seamless. We're not there yet, but AI could make it seamless, which really disrupts models of how we've traditionally deployed healthcare software. And there's this equity issue too, because of course there's going to be a lot of pulse potties listening going, yeah, I wish that was my problem. We're still on paper and we're far away from using AI.
There is that concept of a tipping point, and I suspect we are getting close and close to it. Like when we first started this discussion a couple of years ago, I must admit I was much more skeptical about the role of AI. That's having gone through multiple AI winters in the past. I thought, here we go again. It's going to come around and save the world. But we're seeing it at a whole different scale now, not just the money investment, but just the range of solutions and the things it's getting involved in and the value proposition. Some of these telemedicine propositions that were put through, the examples that we use in the DeepMind paper, in the past, that would have been 2 or 3 clinicians spending a couple of hours when it came down to not just the dollars and cents, but the fact that we just don't have the workforce resource out there being automated by a technology tool, which seems to be right a significant part of the time. And we've had the discussion before. Humans aren't always right either. Whilst we may have greater trust in human decision-making, the evidence is out there that sometimes human decision-making can be a negative thing. Yeah, it's interesting times. I think we're going to see some huge inflections going forward, and who gets it right first may well be the commercial success story. But I think we're going to see just some radical shifts. And as we have more and more of these discussions about how the healthcare system needs to change, layer underlying it may well be that force that takes us through this transition. And maybe in 5 years' time, we'll be looking back on this and saying, wow, yeah, this happened faster than we expected. But if you go back to some of the early work about the singularities, maybe we are closer than what we think we are.
That's it, this speed. And you and I, this is part of our job, is to keep on top of the literature in this space. I don't think I can do that. Like, I'm trying my best, but there is so much to digest. And I actually want to start playing with these things and using them. Have I had time? No, I have not. It's the speed, the trajectory. I mean, at this pace, I think it won't be very long, and the US will probably be there because of their lack of regulation before the rest of us, before AI is not just doing a lot of that thinking, but it'll be doing thinking, acting, and humans will take themselves out of the loop. Just like we don't use the Melways anymore, wherever you're from in the world, whatever your paper directory map of your city, like no one uses those. But now we can't get from A to B without a GPS because we took ourselves out of the loop. Absolutely.
We've read stories about the negative connotations about that. But at the same time, if it means that 95% of the population is going to get value and 5% are going to suffer, then that's the sort of trade-offs that happen in the real world. Hopefully there'll still be a demand for podcasters talking about this in the future.
Yes, we'll try and make that the case. All right, let's go to our next topic, George. Now, in the same week, the big AI companies dropped their clinician products. The journal Science published a paper by Peter Brodeur and US colleagues on LLMs and reasoning tasks. But what I wanted to focus on was a really interesting commentary piece in that same edition of Science by Australian academics Ashley Hopkins and Eric Cornelisse from Flinders here in South Australia. They make 3 points that are worth highlighting, but effectively they say that we've reached a point where large language models are no longer just retrieving knowledge, as we just discussed. They are demonstrating something much closer to structured clinical reasoning, which means we've already passed the point of, look, can AI reason like a clinician? And we're already at the point of needing to ask, can we safely implement that reasoning in clinical practice? And the authors make the point that clinical care is inherently multimodal and messy. We have visual cues, patient interaction, context, uncertainty, workflow constraints, how you're feeling on the day, and how much sleep you might have had or not had in the case for many clinicians. And importantly, accountability. So even if an AI can reason correctly in theory, it doesn't necessarily mean it's going to perform safely in practice. George, what do you think this means for how we think about AI in clinical practice?
I think one of the most important things about this particular paper and the commentary in Science is it's published in Science. So it wasn't published in the Journal of Medical Internet Research, or wasn't published in a classical digital health journal. It wasn't even published in a classical healthcare journal. It was published in Science, which is a 100 plus years old journal that's highly respected. So we're seeing Nature and Science now starting to get into these discussions, which is interesting. But most importantly, that they picked a couple of Australians to actually give the commentary on it. Because as much as I love some of our US colleagues, they tend to follow the hype much more than we do. And Australians are very good at bringing us back down to earth. And the colleagues...
A bit more of a BS detector, would you say,
absolutely,
George?
yeah. We have been there, done that. So smell the roses more often than some other parts of the world. And Ashley Hopkins and Eric Cornelisse from Flinders did a really good job in their commentary on this article. And it has sprung up with a lot of discussion. So if you follow LinkedIn, there's lots of discussion. Graham Walker in particular has had some very interesting comments about this. And Graham's actually coming out to Australia later this year for CCIM.
Yes, he is.
This is a demonstration of that evolution. This model has demonstrated reasoning. And it's interesting because when we start med school, we have no clinical reasoning and no content knowledge. We go through med school and we develop a whole lot of content knowledge. So when we come out, we now know a lot about healthcare, but have very little skill in delivering it. And then the next 30 years of our career as clinicians is spent on developing that reasoning and developing those skill sets that are hard to define, but critical for delivering good healthcare. AI seems to have done it in 2 years. And so it seems to have leapfrogged the way humans do this. Now, is it as good yet? There's some discussion around that. But some of these demonstrations show that in many cases, it's as good, if not better. I think the first point they make there, this is now developing a new evaluation benchmark. We used to use passing USMLE exam as a benchmark, but that's only a benchmark of allowing you to graduate to become a doctor, not being a good doctor. The fact that these models are much more collaboratively configured so that you actually can have multiple data sources providing input into the decision-making reflects on one of the things we've seen in healthcare where multidisciplinary teams play a much more important role in delivering care. So again, we're developing in software concepts that we've been developing in human wetware for generations and struggling to do because there are challenges in having true multidisciplinary teams work together on a single patient. Just the logistics of getting the right people in the right room at the right time to discuss things is complicated. The fact that this can all be done on software, admittedly, in multi-billion-dollar data centers, and there's been a whole thread going through recently about the huge investment in data centers. One of my nephews works for a large developer, and it blew my mind when he told me about a project he's working on. It's a multi-billion-dollar project to just build data centers. And that's in Australia. That's not in the US. Now, the third part, of course, is the accuracy. When you look at the accuracy, depending on your evaluation benchmarks, we're getting some really high accuracies. And 20 years ago, we were talking about to err is human and the low accuracy of some of the stuff we do in healthcare today. Yeah, there's still some work to be done. But the speed of where we've gone from being able to barely pass USMLE to basically mimic some of the world's best healthcare providers in software is amazing. And if I was a young clinician now, I'd be thinking about, okay, what does this mean to my career? I think it means that you need to start to get involved in the AI part of the world early on and don't ignore it because it's snapping at your heels. And
yes. And medical schools are not going to be teaching. Actually, there's now a tool that we use to help us make these decisions and to help us, and this is the critique we need to do of these tools. It'll be years before they teach that.
Absolutely. It's interesting. You compare that to the software world as well. When you speak to people who've done computer science courses at university, they tell you how they were trained on using Pascal. When they came out, Pascal had been obsolete for 10 years. So the ability to learn how to learn new skills is critical. And I think this is one of the things that we're going to have to evaluate in new clinicians going forward. They need that ability to adapt. It goes back to Darwin. They keep on talking about survival of the fittest. No, it's a survival of those who adapt better. And it's really interesting times. And now all we need, like I said, because I'm in the same boat as you, every morning I wake up and seriously, there are 20 articles I want to read in my inbox. Call out, I do use Google Notebook a lot. So I throw these articles into it and say, please give me a summary because I really don't have 24 hours a day to read AI articles.
There is that, yes. And I get in trouble for being in bed for too long. My friend rang me this morning. It was 8:30 in the morning. And she's like, oh, sorry, did I wake you up? I'm like, no, you're just the first person I've spoken to today.
Exactly.
That's why my voice. But I'd been in bed for 2 hours reading AI literature. And I was like, I really should get off my phone and get out of bed and start my day.
So it is scary that I do email you at 5:30 in the morning when I wake up to go to the bathroom and start reading my emails. And, oh, this is relevant to Louise. So you and I are probably spending a lot more time in bed, but I don't think our watches are tracking our sleeping habits quite as effectively. Long time in bed, not too many hours sleeping.
That's right, yeah. But yeah, so look, great article. And George, you were the one who brought this to my attention. So thank you for one of those early morning messages, because I think the guys from Flinders, Hopkins and Connolly did a really good job pointing out something that's really pretty basic to think through, but I haven't seen stated elsewhere, is that if we're already looking at the commentary around the future of medicine is going to be human and AI collaboration from research to clinical delivery, then that interaction between the human and the AI, that becomes the critical system. And yet we're not evaluating the team. These research articles at the moment, they're evaluating a particular model and how that compares to humans. We need to be evaluating what are the outcomes as a team where, and back to that Google DeepMind, that triadic care, we've got a patient, we've got a clinician, we've got an AI tool, if not multiple AI tools. Those things need to be evaluated. And I guess that's where the research will be heading now. All right, George, time for a quick break. And when we come back, we're going to be doing a deep dive into something Eric Topol has pointed out. He's always got great things to say. We're also going to be looking at OpenEvidence, pulling out of Europe, what that means. George, we're back. Speaking of independent voices, Eric Topol has published one of his great ground truths essays this week, and it connects to what we've been discussing on the show already today. So Topol calls it the paradox of medical AI implementation. And you could summarize his essay in one line: proven AI tools, they're being ignored by the medical establishment, while unproven AI tools, they're everywhere. They're getting deployed at scale. That's probably not what we want to see happen. Now, put a link to Eric's Substack in the show notes so everyone can have a read. But he's got lots of examples, mostly from radiology field, of AI that has been proven to be awesome. It works. From mammography, pancreatic cancer, there's some great stuff in there about retinal AI scans and all the stuff you can learn when you put an AI model looking at retinal scans. And I'm very good. I get my retinal scan done regularly. And I would love to put that through an AI. It's not happening yet. Certainly not the last time I went to OPSM. So he points out those sorts of things that we could be using these proven AI models to help with Alzheimer's risk, cardiovascular, a whole bunch of issues. And it's already available, but we're not using it. But then on the other side, we've got generative AI, which has limited and some controversial evidence base, as we talk about on the show all the time. And yet we've got 72% of US physicians using Gen AI for at least one use case, 35% for direct patient care decisions, and at last count, 12% of US adults, so that's 40 million people, use an AI chatbot every day. Myself, I used a chatbot twice today already for health-related things, both related to me, and the advice was so helpful, I now know I don't need to go see a doctor, but I know what to look out for. And if it gets worse, I need to go make an appointment. So Topol's analogy is the right one. And he talks about Waymo, the self-driving car, and how that started in 2009. And it took more than 15 years of rigorous iterative work to demonstrate an over 90% reduction in serious accidents compared with human drivers. But we're only 2 years into this LLM era of medicine, and we're already deploying it at population scale. So, George, we cover this territory every fortnight on the podcast. What do you make of it and what Eric's thoughts are here?
Well, as you said, both of us have been big Eric Topol fans, and I must admit, one of the best moments of our podcast was when we had a chance to interview him. And this concept of the paradox of AI, I mean, recognizing that AI is so much more than just the generative AI we've seen. And whilst it's grabbed all our attention since its launch with ChatGPT back in November 2022, when you speak to real, true, deep AI researchers, they keep on emphasizing how much more there is to AI than just generative AI. And Eric's example is a great one. There was some very early on publicity around the use of radiology imaging, and we have our own Australian success company, Harrison's, which has been world leading in this space. But it seems to be overridden by all the chatbots discussions we've had. The chatbot is going to say, do this and do that and everything else, when the real AI researchers are continuing to do great work in areas that are under the radar. It reminds me very much of the Gartner hype cycle. Everyone gets very excited about stuff as it rises up the Gartner hype cycle, but you actually don't start getting value out of it till it's gone through that trough of disillusionment and starting to go into that plateau of productivity. And I think we're starting to see this in AI. We're seeing it probably in a much faster scale than we've seen in other innovations in our sector. And the one that particularly caught my attention, the discussion he had about retinal imaging. Now, I remember still vividly to this date, the first time I picked up an ophthalmoscope, I was in second year university. We first started doing some of the clinical work in the optometry course I was doing. I had never seen the back of a fundus before in my life. I'd seen images or whatever, but when you pick up an ophthalmoscope, go really close to a person's face and look into the back of the eye, you actually see the cardiovascular system in real life functioning. So you actually see arteries pulsating and veins drawing blood. And because the eye is a pure extension of the brain. So literally you're looking at the structure of the brain. So you have this image which, has so much information in it. We were basically scanning it, looking for things that had gone wrong. But when you start looking at some of the research now being done, and OCTs is a relatively new technology. It didn't exist when I was in optometry school. It's now become a very core part of the way we look at the retina. There's so much information about the cardiovascular system, the neural system. When you look at things like eye movements, it tells you so much about the muscular system that we have access to that we haven't utilized. And Eric made some great points about some of the work that's out there now is allowing us to predict things like Parkinson's, things like dementia 10, 15 years ahead of time. The fact that we're using AI beyond just the generative stuff, and the generative stuff is amazing. It gives us amazing content as far as text and images and videos, some of them fake and some of them having their own sort of challenges around them. Better understanding of what's available in AI comes back to the discussion we had earlier. This is why clinicians need to understand more than just the Time magazine cover version of AI. And that's probably what we start thinking about combined MD engineering degrees in this science. Yep. It's a huge area. The paradox, like you said, is that the article talked about pancreatic cancer diagnosis. I've had a couple of people I know suffer from pancreatic cancer, die from pancreatic cancer. A very close colleague of mine was recently diagnosed with it purely by accident. But they broke their ribs, had a scan to check out their broken ribs and found they had pancreatic cancer. And there's a whole journey about what's happened there. But the fact that the broken ribs may well have saved her life is quite a fascinating story in itself. These are the sort of things that we need to start thinking about. Now, at the same time, we need to think about the implications of this. If we start diagnosing people with Parkinson's 15 or 20 years early, what does that mean? Does that mean you stop living and start worrying about your Parkinson's, even though in that 20 years time, you may get hit by a bus, so you'll never actually experience it?
But then I can take preventative action. And maybe like we had the guest from Evolution, this is what it's all about, isn't it? Preemptive.
And there is that whole discussion about, do we use these tools to prevent disease? Do we actually have ways of preventing disease? I do note that another publication is running a forum in Canberra in a couple of months' time about prevention versus treatment, but no one's actually defined what we mean by prevention. So whilst we may be doing a better job in diagnosing things early, one of the big things we were taught back when we did population health in medical school was that screening tests require you to A, have a test that detects something properly, and B, you have something you can do about it. The value of screening for something you can't do anything about is questionable. So there's some very deep philosophical discussions to be had here. However, the fact is we're doing this so rapidly, we haven't even had time to sit down and discuss what we're doing, yet alone have these deep philosophical conversations. And I think that's probably something we need to start putting some more energy into about what we're doing. The Waymo analogy, I think, is great. 15 years ago, we thought the driverless cars, bah humbug. And yet I remember listening to one of Eric Topol's story where he tells about the Waymo journey is the safest journey he ever has. We're starting to see this evolution happening, but we're just seeing it accelerated at such a pace that we can't keep up with it within our current mindsets.
Yeah, that's right. Actually, a friend was in San Francisco recently and I said, did you take a Waymo? Because it's there for a few days for businesses and stuff. He said, no, I'm running late and I don't have time to get into a Waymo. And I was like, what do you mean? They're so safety conscious, they don't... it's much faster to get into an Uber than the Waymo. I was like, okay, fair enough. There'll come a time where, it will be safer, and there'll become a time as well. And I've asked some of the insurers about it where it's, hang on, what? You didn't use AI as part of your clinical reasoning? That's a medico-legal risk. You relied on your own tiny little human brain and thought that you knew better than the world's knowledge base at your fingertips as a tool.
I think that is coming up more and more. And like you said, the fact that we're at the moment are still preferring speed over safety. But things will change, and it's interesting times again.
Absolutely, yeah. All right, George, now we have another AI-related story here, but I know this is a tool that you have some experience with and you've talked about it before, OpenEvidence. So this story's been brewing for a while and it landed last week in a way that I think we need to discuss because every health system, every regulator and every clinical AI vendor should be paying attention to this stuff. This is very much a global story. So OpenEvidence is the most widely used clinical AI platform. It's used in the US daily by over 40% of clinicians across more than 10,000 hospitals. It's had a history of 18 million clinical consultations. That's just for the last December alone. It's probably gone up since then. And we've talked about it before. They're worth a lot of money. We're talking about they did a Series D at $250 million in January at a $12 billion valuation. Like you said earlier, George, when these big tech companies get involved, the zeros on the end of the numbers are just substantial. Now, on the 28th of April, OpenEvidence quietly geofenced itself out of Europe and out of the UK, citing regulatory uncertainty regarding the treatment of AI systems. So it wasn't banned. There was no regulatory action. This was a voluntary withdrawal. So a company that stands to make a lot of money in a market, they went, no, we're just going to pull back from that. And this is, I think, where we're headed, where regulation could just shut down innovation, but if it leaves it to go unchecked. But when we don't do either of those things, we have this uncertainty about regulation, which means the tech companies themselves, or probably more appropriately, their lawyers, will advise them to mitigate risk by not making their product or service available in that region. And so it provides this really real tension. So regulators have legitimate reasons to want validated AI in clinical settings. And I know, George, you and I are a fan of regulating these things. But the most useful tools sometimes cannot be made available, and then clinicians find workarounds and use them anyway. And I'd love to get your take, George, on what you think of this regulation versus innovation argument. And is the EU protecting patients, or are they excluding them from a service? And in this instance, excluding clinicians.
So it's interesting. So the EU is basically the second largest market in the world. It's 500 million people. As far as money goes, it is second only to the US market. And let's be honest, we've seen the US market has a lot of waste in it. And the Europeans have a reputation for being overly bureaucratic. The European Union is a combination of 42 countries trying to agree on a common framework for many things. Yeah. And as a result, we've seen lots of discussions. I actually had opportunity to visit Brussels a few years ago and visited some of the European Union's facilities. I mean, they've basically half of Brussels is European Union buildings and bureaucrats, and they have their own European Parliament. And it's interesting, the fact that they're probably on the other side of the pendulum from the Americans who under the current regime tend to be thinking about bureaucracy be gone, we'll get rid of all the bureaucrats and let the free market work. Somewhere in between there is probably the right answer. We all hate bureaucracy except for when it comes along and saves our lives. So I remember people complaining many years ago, the bureaucrats are making us wear seatbelts, but then we found out that people actually didn't die in car crashes because the bureaucrats made us wear seatbelts. And there's a whole bunch of examples of those sort of bureaucratic measures which appear to be negative to those of us who bear the brunt of them, but there is some logic and thinking behind it. And in this case, the software as a medical device discussion is an important discussion. These tools are involved in actually making clinical decisions or significantly influencing the clinical decisions. And I think this is where the European discussion here arose, that whilst we say open evidence, I love open evidence. It's a great tool. It's an LLM based on clinical information. It really does provide some very accurate and very well documented decisions. But the idea is behind it, of course, is that it's a tool that clinicians use to make decisions. The reality is often it just overrides what the clinician's already thinking, and it's just easier to take that information. So it is making a decision. And so therefore we need to put some guardrails and guidelines around it. I think the key thing, and again, we've discussed this earlier, AI literacy, having clinicians who know the pros and cons of AIs, know how it's making decisions, moving away from some of these black box models. And if you look at the CPD requirements for clinicians in Australia, they're a bit vague. Maybe we should be saying, well, 20% of your CPD should be around understanding some of these new tools coming into the market and how you use them. And if you are going to be using these tools, maybe you need to be certified to be safe to using, not necessarily just the tool, but the tool and clinician combination may require certification as well. My concern is that sometime down the track, there may be a multi-million, if not billion-dollar lawsuit, which becomes a precedent, which changes everything. Before we get to that, hopefully we can actually start having a better understanding about the tools. I note that the Australian Commission on Safety and Quality in Healthcare recently brought out some interesting discussions around their role in certifying and managing digital health tools. We are having a broader discussion about it, but to some degree, like you said, the horse may have already bolted. If I can't access it in EU, how hard is it for me to load up a VPN and pretend I'm in America and pull up the tool? We know that dissidents in Iran and in Tunisia did this 10 years ago. So I don't think that we're really going to be able to stop doctors and other clinicians from firing up their VPN and saying, oh, yes, I'm currently in Chicago. The bureaucracy alone itself won't solve the problem. It does help us highlight the problem, but education, AI literacy, engagement, collaboration between, there's a whole bunch of work that needs to be done here.
Yeah. And it just goes to show as well, when regulators aren't certain of what to do and do nothing, then it's up to the tech companies themselves to decide what they think their risk is and whether they want to be in the market or not. But then there's also puts a lot of pressure on clinicians. I don't know, like I did a Google, I asked ChatGPT, it said this tool was good. I guess I'll use it. My friends are using it. This sort of stuff will happen when we really need to provide good quality evidence and to have national bodies or bodies with authority who can speak knowledgeably about this stuff and refer to the evidence and give clinicians and health services the tools they need to evaluate it themselves or to know that under this guidance, this is what I should do. Clinicians are too busy to actually have to add this burden on their list. So I think we need to do a lot better job of supporting clinicians in this era.
Look, we're pretty lucky here in Australia. We do have some very good academics in this space. Enrico's group, Macquarie, the people we spoke about earlier from Flinders. I think we're in a better position than many other countries. But the reality is this is a global issue. We're struggling with it in highly developed, highly resourced segments like Australia. What happens in Zimbabwe? What happens in countries that are spending 1/1000th of what we're spending on healthcare? How do their clinicians get involved in this sort of discussion? I think that's really need to start thinking about this on a global level.
Yes, absolutely. All right, George, I think given how much you and I have talked today, that's probably the end of our hot topics.
Well, again, interestingly, I think AI was the key part of our discussion. Hopefully AI won't be replacing us in the future and doing the podcast for us. But if it does, then you and I will have to find another way of keeping ourselves amused, Louise.
Yeah, that's right, George. Now, did you have any recommendations for the Pulse Potties today?
Just a comment I'd like to make. So one of the things that did happen during the week was the passing away of Craig Ventnor. Ventnor, as many people will know, was the guy who basically drove the genomic revolution by being the first one to develop a whole human genome sequence back in the 2000s. There's stories of him and President Clinton coming out saying that this is going to change the world and medicine's never going to be the same. He's done a lot more since then. He's done a lot of work around microbiomes. He did some synthetic life forms in bacteria. He did some research around bacteria that's found on the ocean floor and its effect on the life. One of the ironic things, of course, is that he was also the founder of a company called Human Longevity Incorporated. And yet the founder of Human Longevity Incorporated lived less time than the average longevity human. So it just, again, highlights the complexity of human health and physiology. But I think it's important to say here that the work he did is very significant. It shifted us from the old paradigm of healthcare to this new personalized model of healthcare. So I think we really should be remembering that Craig Ventnor's work has played a huge role in transforming the way we think about healthcare. He has some interesting stories. For those of you who get a chance to look up Wikipedia and read his life story, it's really quite an interesting story. But I think we just need to make sure we take into account that someone who's played a significant role in the way in changing our thinking about healthcare passed away. And as we say in my faith, may his memory be eternal. But for those of you who want more work, he's published a couple of books and a couple of writings which are worth reading because they really are an insight into new models and new ideas that we probably haven't got our heads around yet.
Oh, thank you, George. And thanks for those words. And we'll put a link to some of those articles and references of Craig's in the show notes as well.
Yep. What about you, Louise?
Oh, I just wanted to give a shout out to the Australian New Zealand listeners that the workforce census is now up and running. So we'll put a link to that in the show notes and just encourage people, if you work in the field of digital health, health informatics, health information management, all of those things that come together in the Venn diagram, that is digital health, please fill out that survey. So we'll put a link to it in the show notes.
One other thing we should note, again, this is coming out after ITAC. So if you were at ITAC, I hope we have a chance to catch up. But coming soon after the release of this podcast will be Digital Health Festival. So Louise and I will be together in Melbourne, along with 8,000 of our best digital health friends, or whatever the number is this year. We're interested to see what the new event looks like. But reach out to us if you're going to be at Digital Health Festival. Let's have a chat. Louise and I are on a couple of panels and sessions, but it's always a fun time. And there is the big party afterwards. We're not going to the party. We're going to a dinner, from what I understand, Louise. But
I know the amount of people are like, see you at the party. I've got tickets to the party. And I'm like, I'm doing an event. I'll be working that night.
Maybe we'll crash the party late.
Maybe afterwards. Let's see. All right. Thanks, George. I will see you in Brisbane. In the meantime, if you could please read us out.
Thank you all for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara from Pulse IT for her support. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. Visit pulseit.news to catch up on all the news from Australia, New Zealand, and Ireland, and send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. See you soon.
Bye, everyone.